Welcome to episode 190 of the Crisis Jam, our 988 learning community. I'm David Covington. I'm the host of today's episode, and Karen Jones and I curate this program in partnership with SAMHSA and NASBD. And we're so excited to have our team from Kentucky, Angela Roberts and Dr. Ryan Combs, on marketing for LGBTQ plus and African Americans today. And we just saw a great video from SAMHSA about marketing to farmers, a Mind Your Melon. So lots of amazing work focused on specific audiences and getting through to people who may need support and care. And for us at Crisis Jam, we want to bring those stories from every state, every territory to our community. We have featured over the last 5 years 34 states and territories. We have a few that we're still targeting, and Kentucky is one of them. So today, we'll bring Kentucky on board and highlight 35 states. So if you're Kansas or West Virginia, we want to have you in Stephanie Hepburn's Crisis Talk interview or with a featured presentation. So look forward to all of you joining us. If you want to go back and see one of those prior programs that highlighted various states, various initiatives, then talk.crisisnow.com is the site for you. It's the straightforward way to register and keep up with the Crisis Jam, as well as go back to all of not only last week's featured episodes, but all of the programs that have been done over the course of time are readily available to you. In the news, NAMI's Next Gen is once again soliciting applications for another cohort of young people who want to change the world with their voices to come to the table. And it's not a token seat, it is the whole table. And we've been thrilled by the engagement we've had the privilege to experience with some of their prior leaders. You see Trace in this picture. We've had Sophie and Maddie and others from NAMI Next Gen as a part of the Crisis Jam, and hope that if you know someone or you would like to outreach, we'll put that link in the chat. Today, we're going to start a new segment, the Lived Experience Library. And Allie, thanks for joining us. Allie, you are a new author. Now, I've been talking about becoming an author for at least 10 years, and apparently it's a lot more work than I thought. I can't get across the finish line, and you seem to do it in a matter of weeks. What is going on, Allie?
I think it's just like once I realized that I had a story to tell, like I just couldn't stop until it was done. And it was hard, and there would be times where I'd like get an idea when I was like sitting and playing with my kids, and I'd be like writing little notes on my phone, so the second I could put them to bed, I'd be, sitting and writing and telling my story. And so it was a lot of work from start to finish. It was 3 month, but
3 months. Well,
it was worth every minute.
I actually got my package in the mail from Amazon. I haven't opened it yet. I wonder how hard this is to open online. But Allie, I've got your book right here. Let's open it up for the audience. And there it is, Running the Endless Race. I have read almost all of it. And Allie, our families, we know each other. So the stories of your mold house, it's an incredible journey that you've shared with us. Allie, thanks for joining us. We're going to go on a quick little trek here together. And the first thing we're going to do is I thought I'd have you as my partner in the Crisis Trivia Hot Seat. We're going to poll our audience today and tell a little bit of the story as we set the stage for Allie's book. Before 1990, public accounts from suicide attempt survivors like Allie were rare. Today, hundreds of individuals with lived experience are reshaping our understanding of pain, crisis, and recovery, offering new perspectives on how to provide hope and support. And Allie, you weren't wanting to tell your story more than any other people, but the examples really shaped the way. So for our audience today, and we're going to put this up, Allie, you want to read our question and give our answers for the day?
Yes. So which author was first to break the silence around suicide attempts and mental health struggles?
So was it Kevin Hines, Kay Redmond Jameson, Marsha Linehan, or William Styron? Allie, I'm looking at the audience and they don't know. There is a runaway lead for Marsha Linehan, obviously the worldwide intellectual thought leader behind dialectical behavior therapy, an amazing change maker. And of all of the efforts to prevent suicide, Marsha's work might be at the top. It's certainly one of the most influential. She's leading the way. Let's go ahead and share our results. And so people say Marsha Linehan. Do you know the answer, Allie?
I don't know the answer, but I can tell you my lived experience of the first story I ever heard.
Let's
and
hear
that was Kevin Hines.
Yeah, so Kevin Hines was the first story that moved me to understand. It was like, okay, so he jumped over the rail and he described an experience that historically we mapped to people who we called it gestured, that weren't serious. But Kevin would have died, could have died, should have died, didn't. So it was, I'm not sure anything I believed about suicide was correct. Kevin for me as well. But the answer is William Styron. So William Styron, one of the leading American novelists of the 20th century, Pulitzer Prize winning, he wrote a New York Times op-ed after survival in Auschwitz author Primo Levi's death was ruled a suicide, and he was dismayed by the reaction to his piece. People said a survivor of Auschwitz wouldn't die of suicide because they weren't that weak. And it really piqued William Styron because he had lived a suicidal depression, Allie, and he knew it wasn't about weakness. So he landed up saying, I'm going to have to write a book about my own lived experience. And he did that. Levi's supporters and scholars rejected the notion. Styron felt compelled to share his own story as a survivor. And he wrote this: the argument I put forth, which started with a public lecture, led to a New York Times op-ed, and then he just had to write a book. The argument I put forth was fairly straightforward. The pain of severe depression is quite unimaginable to those who have not suffered it, and it kills in many instances because its anguish can no longer be borne. So it's just an amazing story. William Styron opened the floodgates, if you will. K. Redmond Jameson in 95 and 99 wrote An Unquiet Mind and Night Falls Fast. Allie, we're not going to go through all these books, but we do hope to have the authors themselves or authors adjacent. I'm not sure we'll get Marsha Linehan on, but Ursula Whiteside was in Marsha Linehan's shop for many, many years. Marsha's older now. But we're going to go through these amazing books. And if you are a fan of this type of work and would recommend a book to add to our library, Kevin Hines' Cracked Not Broken didn't come out till 2013. And Marsha Linehan's book didn't come out to 2020 because she, for decades and decades, did not tell her story of being a suicide attempt survivor. Her patients would say, "You're one of us." And she would say, "Do you mean someone who cares about this work?" And they would say, "No, we think you're one of us." And she eventually came out in the New York Times in 2012 and wrote a book in 2020. So we're going to go through these authors over the course of the Crisis Jam. But Allie, 2024, you published a book. What's it been? 2-3 weeks ago now?
Yeah, about 3 weeks.
And last week, John Brogden, another leader who's was actually one of the top political leaders in Australia, has been on the Crisis Jam, wrote a book, Profiles in Hope. Allie, tell us your favorite thing about running the endless race and why people should run out and purchase this from Amazon and add it to their library.
I think my favorite part is that the fact that I worked really closely with my publisher on discussing how we wanted to form the story, and I wanted to tell enough detail that it tells my story and the things that I've gone through, but keep it vague enough where everybody can relate to the feelings that I was feeling as a girl or in life in general. And so I think that is my favorite part, is that the people that read it will see bits and pieces of themselves in the story. And if they can see the things that I've accomplished with some some of the adversities I've faced, then what are they going to see in their own future, and what doors are going to open up as possibilities for them?
Yeah. My absolute favorite part of Moving America's Soul on Suicide is you saying you didn't want to hear that it gets better. You wanted to hear that you could do hard things.
Yeah.
And Allie, you did a hard thing. You were you did your first speaking engagement in Connecticut a couple of weeks ago now on World Suicide Prevention Day. You got a standing ovation that Dr. John Santapietro was telling me about. How was that experience?
It was incredible, right? Especially as someone that has always had a lack of self-worth, or always felt like I wasn't good enough, to get the validation from actually sharing my own experiences, the good, the bad, the ugly. Like, I didn't hold back during my speech, and yet people, stood up for that. People were willing to clap and celebrate the failures and the wins, and that was absolutely incredible.
Allie, thanks so much for joining us. The first in our new lived experience library, bringing authors on, and we'll bring more. Look forward to your feedback too for what we're missing and who you'd like to hear. Thanks, Allie. Stay with us.
I will. Thanks, David.
And now Angela Roberts and Dr. Ryan Combs are with us from Kentucky. Team Kentucky, tell us about the work you're doing.
Great. Thank you, David. And thanks to everyone for allowing us the opportunity. So what we wanted to come and talk about today is our marketing efforts specifically for LGBTQ and African American populations in Kentucky. This work started a little over 2 years ago when we started looking at the data and recognizing that there was a need to increase awareness. We kind of dug in and we saw that there were increases in suicide rates and suicidal ideology. And we also recognized that there was a stigma around calling for assistance. We talked to different groups we worked with internally to identify what we needed to do, because as 988 was launching, we wanted to make sure it was accessible to everyone in Kentucky that was experiencing a crisis. Next slide, please. So Dr. Combs and I are here to present today on what we've done, and I'm going to give you a little background on where we came to land on this marketing campaign. So we decided in 2023 we wanted to do an awareness survey of Kentuckians to find out about those who knew about 988 and whether or not they would use it. So what you're seeing here is a representation of some of the responses when asked the question, when should someone call 988? So we had over 1,700 responses during the state fair last year. And it was not a representative sample because we did it by convenience. So anyone that came by our exhibit or our display, we engaged them in conversation around 988 and asked them to take a survey. Sorry about that, I just got muted. So we asked people that came by during the state fair to take our survey so we could gauge the awareness on that. What we found in the responses is that predominantly white, straight, or heterosexual females that presided in the suburban areas of all ranges were the ones most familiar, or the ones who took the survey to tell us about their awareness. So we did the survey again in 2024 to kind of compare. And similarly, we got the same type results when it came to the respondents that we encountered and the responses to when individuals should call 988. So next slide, please. What we found out in 2023 and pretty much again in 2024 when we did the survey again is that Black or African American Kentuckians and those with that are of the LGBT communities had very high awareness of 988. But what we also found with that is that it mattered with age brackets. So those who were 55 and older had less knowledge of 988 when compared, and that there were The bisexual, queer, pansexual, or questioning had higher awareness than lesbian, gay, or heterosexual respondents. So we found that rather interesting with that and recognized that there was a need to make sure there is awareness and a reduction of the stigma when it came to contacting 988. So next slide, please. One of the things that really struck us is that while LGBTQ and African American Kentuckians had the highest awareness of 988, they were also least likely to utilize 988. And we recognized that that was a significant barrier to making sure Kentuckians had access to the crisis continuum. We did it again this year and found pretty similar results with that. So we knew that it was important for us to make sure we were reaching our LGBTQ and African American Kentuckians. So a little over 2 years ago, as I said, we started this project with in partnership with the University of Louisville School of Public Health. And my colleague, Dr. Combs, will take you through how we've gotten to where we are.
All right. Thanks very much for having me. So I'm going to talk to you about the process that we used to come up with recommendations for an ad campaign, with the caveat that this campaign is still in development, but I want to kind of bring you up to where we are today and drive the point home that community engagement is essential to developing marketing messages that really work for the community that you're focused on. And in Kentucky, as Angela said, we're focusing on African American Kentuckians and LGBTQ Kentuckians with this particular effort. And there are other efforts underway to target veterans, farmers, and other priority groups. Next slide. All right. So in order to do this community engagement work, we used a process called bootcamp translation. It's a process of bringing community members in the audience of focus together with an academic team and health and public health professionals. So Angela's group, some people with expertise in mental health and expertise in the 988 Suicide and Crisis Lifeline, and bringing all of these folks together to determine what do we want people in the community to know, and also how can we effectively share this information with the community in a way that really works, that's really locally relevant. So what works for us in Kentucky, the messages that land with folks in Kentucky will be different than the messages that land in other parts of the United States and the world. So knowing that these that folks have different preferences, it's really important to actually talk to people about what works and doesn't work for them. So as part of the bootcamp translation process, the bootcamp part is that the first thing we do is all meet and learn. It's like a knowledge boot camp. We all meet together and get on the same page about what we're trying to accomplish. So for community members, these are folks that may not necessarily have lived experience with their identities, lived experience as people, as Kentuckians, but not everyone who participated had the information that they needed about the 988 Suicide and Crisis Lifeline, about mental health, about crisis care. So the bootcamp part of bootcamp translation was getting everyone together to really learn and make sure everyone was on the same page with the science and with the kind of technical information as well. We determined the information that the community needed to know. And in this case, it's quite straightforward. We want people to know that 988 is a resource that can be accessed by anyone in the community who is facing a mental health concern, a crisis situation, and also, if you've got other people in your life who are experiencing crisis, 988 can be a resource for you as well as you're trying to assist others. We determined who needs to see the message. We determined what we want people to do. Once again, for this particular campaign, it's pretty straightforward. We want people to pick up the phone and call. And then in the creation phase, which is the phase that we're kind of in the middle of now, what messages, materials, and dissemination strategies will get these messages into the community? So in the bootcamp translation process, I want to make the community engagement approach really clear because, again, these are things that other people can do in other areas with the right facilitation and expertise. The bootcamp translation was founded in rural Colorado. It's been used all over the country, and I've used it in Kentucky several times. But when you do one of these processes, it's really important that these relationships are long-term. So each bootcamp translation takes between about 6 months and a year to complete. Everyone who is there has to participate. So there are no observers. Everyone is bringing expertise, whether that's me and my facilitation expertise and my research skills. A community member is bringing their lived experience. You've got people there with all sorts of expertise, and everyone there. We try to keep the value of that expertise as equitable as possible so that no one person is kind of calling the shots. It's really about collaboration and about trying to reach consensus. We identify everyone's expertise, but no one is speaking on behalf of the community they are a part of. So, for example, I'm part of the LGBTQ community. I'm in the room, but that doesn't necessarily mean that I am speaking on behalf of every single person in the LGBTQ community. That's too much to ask. It's too much pressure. So we're all speaking from ourselves and on behalf of ourselves and our experience, and not our organization. And the reason why we do that is so that people can feel comfortable. They're not necessarily having to, make sure I'm saying the right thing on behalf of my company that I'm an employee of, but they can kind of speak a little bit more freely. So the way that we did this is we had two distinct groups. We had a group focusing on African American Kentuckians and a group focusing on LGBTQ Kentuckians. In those groups, that doesn't mean that you cannot be LGBTQ in the African American group or African American in the LGBT. There's overlap, of course, but we wanted to make sure that we're kind of developing campaigns for these particular communities separately because they have separate needs from each other in some cases. So the African American group, some of the messages that the group members came up with, 988 is the mental health alternative to 911. There was some talk, for example, about 988 being almost a harm reduction strategy for the caller to calling 911 because 988 call takers have more expertise in mental health. People were interested in understanding what happens when you call 988, so getting the community more specific information about the process, getting the word out that help is available, getting the word out that people are worthy of help, and the idea that 988 is for us. So so the group was really interested in Afrocentric messaging and really establishing that 988 is for African Americans as much as any other group. Next slide. LGBTQ community group was really interested in empowering messages. In the state of Kentucky, sometimes things are a little rough for LGBTQ people. There's a lot of, talk. The people can overhear things, stigma, discrimination, that sort of thing. And so the LGBTQ group really wanted to kind of latch on to empowerment messages. You're worth it. Stick it to them. Stay alive. Basically saying like, we're here. We are deserving of help. They also wanted to convey that there are multiple ways of calling 988. So you can call, you can chat, or you can text, which was important for the intergenerational accessibility of the helpline. You've got options. You are in control. And 988 is for mental health. So we presented this feedback to Doe Anderson, which is our advertising agency, and they came up with some campaign ideas. And this is the point that we're at right now. This first marketing concept is in a barbershop, a salon, and lots of people are getting their hair cut, and the person who is cutting the hair is saying, you may not be ready to open up to me, but there's someone who's there to help, and then giving the 988 line. The feedback to this is that the beauty shop or the barbershop idea does not necessarily resonate as much with the LGBTQ community here. And so we've suggested to Doe Anderson that they switch it up to be a coffee shop and also make it a little bit more intergenerational. So we wanted some age diversity in the ad. Next slide. This was an ad that we actually preferred the first campaign to this one, but this was another idea that came up with. The real you matters. So that idea of the real you, the true person, did resonate, but the visual images were not as resonant with the LGBTQ group. Actually, can I go back one slide? I want to talk about the African American group really fast. So the African American group did like the barbershop beauty shop idea. We wanted to make sure that Black men were in the ad as well, because it was quite feminized as presented. So we want to make sure that there's gender diversity to make sure to reach Black men. But the barbershop beauty shop idea was one that African American Kentuckians in our BCT group were pretty excited about. There was another thing that I just wanted to highlight. It's not on the slide, but there was a message that said, "We're here for you too," like "We're here for you, comma, too." And both groups recommended that we take off the "to" as to not other African American populations or LGBTQ populations. So that was something like "We're here for you" is enough, rather than "We're here for you too" as if it's an add-on. All right, next slide. I just want to hit home a couple things. First is that tailoring messages for diverse communities is incredibly important. Not every, a general message is not going to reach specific like pockets of the community that have different needs. And I would encourage all of you to do community engagement, engage with your, if you got academic connections, engage with health professionals, researchers, and community members to get the messaging right. Bootcamp translation is a useful tool for doing this. If you have any interest in doing this, you can feel free to contact me and I'll give you some information about bootcamp translation. And our next steps, we're working with the advertising firm and continuing collaboration to make sure that we get the campaign right. Okay, that's all for me.
Thank you, Angela, Dr. Combs. Tremendous work you're doing. Lots of feedback in the text chat about the engagement of people with lived experience, really making this a about us effort and then iterating on that as you get feedback. So terrific. I'm wondering, how did you roll any of this into 988 Day? What did that look like for Kentucky?
Well, one of the things that we've done, and we're continuing to do it with these projects, is create state-specific messaging. So we were able to disseminate it out, but we also gave all of our centers the freedom to express 988 in the way they chose to. So we've had a lot of different ways of doing that. We've had TikTok videos made where we had one center that was involved in a parade promoting 988. So there's a lot of different ways that we do it. Another thing that we've done, and we did this intentionally for 988, is we launched our data dashboard over the weekend of 988 Day. So we were able to share that and encourage people to go look at it, because the message we want is that 988 is for all Kentuckians in crisis. But we also want to highlight the fact that our centers are amazing and the work that they do matters, because we have an average of 2% or less of all of our calls involve any type of emergency services. So we're able to de-escalate 98% of our calls, and that's highlighted through the work that we do on our dashboard. And I will drop the link into the chat so people can take a look at that.
Great stuff. Angela, you referenced the percentage of time that law enforcement's involved. Dr. Chris Drapeau at Vibrant, formerly with the Indiana 988, I just published a research study on this issue. It was also covered in the national media. We didn't get it into Crisis Jam today, but Matt Goldman, I know we have a data corner coming up. Let's talk about getting Chris Drapeau on to jump into that issue that Angela raised a little bit more. I'm wondering if we're going to get to the SAMHSA update here in just a moment, but Stacy, I wonder if you have any feedback or questions or comments after hearing Angela and Dr. Combs talk about the targeted marketing in Kentucky for 988.
I just want to start with saying, fantastic work, Team Kentucky. The use of really doing your audience research to drive your campaign work is spot on and how we always talk about doing the marketing. So really love how your whole process and how you're working through and the work you're doing. Thank you.
Yeah, terrific, Stacy. So look, there's a lot of us are engaged in the software space today around crisis care. And one of the things I've seen from working with really great software folks is it's always about the user experience. And that's the whole thing. And Angela, Dr. Combs, to see you guys so focused on that, and not only the operations, but the engagement. Terrific work. Thank you, Angela. Thank you, Dr. Combs. And with that, let's go to Stacy and our SAMHSA update. And we're going to jump into a little bit of you've been measuring the impact of 988 Day. It is pretty incredible.
It is amazing. And, just first off, want to thank everyone here on Crisis Jam, everyone who participated in 988 Day. We went into it with not a lot of time planned and just said, here is our call to action. No judgment, just help. It's actually a tested message that we know is testing really well with our audiences, which is why we gave it out as the theme this year. And, we put it out to everyone and the response has been fantastic. We didn't really know what to expect. We just said, oh, we hope our partners are going to do something. And it really, really, you guys blew it out of the park. So you want to go to this, if you have the slides, next slide. So this is so you guys can see what happened on social media during the 988 Day, which a lot of you turned into about a week and a half, actually. We had 6,500 mentions of 988 Day, 5,200 uses of the hashtag. We had 2,800 unique users participate. A lot of you came to the social wall. People were really, really engaged. We had a lot of creativity. Just to kind of caveat a little bit, we aren't able to capture numbers from LinkedIn or TikTok because of lack of APIs on their sides. So these numbers don't even account for what we saw on those platforms, which was also, a lot of creativity. So next slide. Then the other thing that we did was a very large broadcast media push. Monica Johnson, our director, was out there on a lot of different local stations. She did feeds with CNN News Source, with Fox, just a whole bunch of folks. That resulted in 1.8 billion potential audience for all of the broadcast TV work that we did. And next slide. And this is just a few examples that I pulled from the amazing social wall. If you haven't gone there, it's still up. You can see it. But MTV posted. We had through AFSP, Papa Roach and Carrie Underwood with their new song, Talk Away the Dark, I think is the name of it. I can't remember the name of the song. Their campaign is Talk Away the Dark. And Papa Roach is still posting every day or every couple of days on his Instagram promoting 988. He just posted one that I saw this morning that was, I'm reading all of your comments and people are just, posting their heartfelt stories out there. Deftly did a fantastic, really cute recipe for mental health. We had counselors from crisis centers around the country who were posting videos about what they do, which is such a big thing. We know how many people really are wondering what counselors do and what happens when someone reaches out to 988. We had politicians who posted. The Papa Roach video, actually, they did a lot of extra promotion. So we had a lot of celebrity reach on their work.
Stacy, great stuff. Wow. And who knew that we were going to have Papa Roach and Carrie Underwood? We got Eminem coming here in just a second. That's never happened in Crisis Jam before. Really, you're talking about 2 billion engagements. Monica's little video I saw on the wall was just terrific. So many folks from Crisis Jam. Debbie Atkins was wearing a 988 shirt on a plane. That one I saw a lot of times. And then we started, if you were in the pre-show, we showed a quick Faces of 988 video about farming, but I guess that's a whole series as well. And it evokes what Karen Jones, our organizer on a lot of this work, was looking at and thinking about the work Kentucky is doing, but these targeted messages and saying that this is for everyone. Reflections on that Faces of 988 video.
So the Faces of 988 video, which is actually Mind Your Melon, it's a farmer who lost his father by suicide. We actually produced that video and re-released that video at one of our road shows early on. And we were originally thinking that we were going to do a whole Faces of 988 series. Some of you who were participating in our road shows, we actually did a lot of videos, and we are now using those videos in our marketing materials that we've been working on. But we're not calling them Faces of 988 anymore. That was our first idea. And, as testing goes, things change a little bit. But I was so happy to see him come back on and reshare that because it was such a powerful video.
Terrific. What are you calling them now, Stacey? Do you remember offhand?
We actually are more just internally calling them testimonials, but they're just a part of
stories.
They're stories. There's real people, it's really important. We get it that people have to hear real people talking about either answering 988 or reaching out to 988. And that's a lot of our focus.
Love it. Love it. So Stacey started with the doggy on TikTok. So I asked our amazing team to go and find that. And we're going to share just a few seconds of doggy and 988. So Eminem and Doggy and 988, amazing work, Stacey. Wow. I just think back to before we launched this number 2 years ago to today. That was an amazing day, and look forward to when will you start thinking about the theme to follow up? No judgment, just help for next year.
We're already talking next year. So just know, we gave everyone very little notice this year that it was going to happen. We're already working on next year. Everyone will have a lot more advance notice. So, we're just going to have to do even better next year.
Love it. Love it. Thanks so much, Stacey. Let's go to Elizabeth Sinclair Hank with NASBD. Elizabeth, welcome.
Yes, thank you, David. And happy Crisis Jam Wednesday, everyone. Hard to follow Stacey at Samson M&M, but we also have some exciting news from NASBD this week that I'm excited to share with you all. On Monday, SAMHSA announced the release of the 2024 Technical Assistance Compendium titled Connected and Strong. The compendium is comprised of a series of 10 papers that reflects the current best thinking toward advancing SAMHSA's vision of crisis care that's available 24/7 and responsive to wherever the person in crisis is located. Connected and Strong was produced by NASBD on behalf of SAMHSA as part of our partnership to develop a series of 10 technical assistance papers every year on moving beyond beds to creating a full continuum of care for those in need. As you can see on the screen here, these are the, what are we at now? We're in the 6th year of these papers. And while I officially only joined NASBD earlier this year, I've been working behind the scenes with Dr. Peinels on these papers since the first Beyond Beds in 2017, and I'm thrilled to be sort of more out in front on these and sharing them with you all. What we call the umbrella paper, which is sort of the lead paper of the series and attempts to tie all of the 10 together in this year's Connected and Strong. It lays out a framework for advancing crisis system development in the post-implementation phase of 988 that we're all in, 2 years now. Central to this framework is an emphasis on providing multiple levels of care through various access points and ensuring timely and appropriate interventions. I wanted to be sure to give a shout out to my colleague Jenna Schofield, who co-authored this umbrella paper this year with Dr. Peinels. There are many excellent papers in this series, but I wanted to call your attention to just a few in particular. The first is written by my colleagues Amy and Justin at NASHBID and discusses peer support services across the crisis continuum. It provides a great framework for how to integrate peer support throughout the entire crisis system. The second I want to highlight is a paper that focuses on 988 and 911 collaboration and includes some great state examples that other states can be using as they're looking to promote collaboration between their 988 and 911 systems. And lastly, I wanted to call attention to the 9th paper in the series that is written by our friends at NAMI that highlights the role of faith-based partnerships in increasing access to behavioral health care, particularly those of historically marginalized and minority communities. And I think the link to the SAMHSA announcement on SAMHSA's website, as well as the NASHBID website that has all 60 papers since 2017 will be in the chat shortly. So thank you. Back to you, David.
So Elizabeth, this is really amazing work. And it's actually 70 papers at this point, 60 that are on the NASHBID website, and the 10 new ones that are now on the SAMHSA website. You know, the phrase that we've used over the course of time is gentle pressure relentlessly applied. But you need the space to focus on something. And behavioral health over my career, it seems like so often you have to pivot continuously and you can't quite get a focus. And the leadership of NASHBID and SAMHSA since 2017, keeping this focus is, I think, in large part why we've made such tremendous gains. So great work. Thank you for yet another 10. Do we know the theme for 2020, well, going into 2025, connected and strong in 2023, 24? Are you ready to share that, Elizabeth, or what's happening on the next version?
Yes, the next year, 2024 part 2 or 2025A, whenever we'll get it released, is on advancing crisis care and provides 7 steps that are practical steps that states can be using to advance crisis care using the advanced acronym ADVANCE. So yeah, we're looking forward to sharing with you all.
Terrific. So some real clear action steps and practical
Exactly.
steps. So great. Thank you so much to NASHBID. Wonderful. We're running just a little bit ahead, but we have a lot of content today. So Dr. Matthew Goldman, we've got the data corner coming up, and you're going to introduce to us Megan McDaniel. Take it away.
Awesome. Thank you so much, David. Pleasure to be here. Hello, everyone. I'm Matt Goldman, and am thrilled to introduce Megan McDaniel, who's going to share some results from a research study that we conducted back when I was in San Francisco. This is a research study that was funded by the Robert Wood Johnson Foundation, and it is an analysis of a exciting program that launched just a few years ago. We did a whole big mixed methods analysis, and Megan's going to share some of our qualitative findings. So I was the principal investigator on the study, and Megan was our amazing research assistant, and I'm excited for her to share some of these results. So Megan, take it away.
Hi, everyone. Thanks for having me here. All right. So sorry. Okay. So I am here to talk to you about our qualitative study on the Street Crisis Response Team in San Francisco, or SCRT. So this team is a 24/7 911 dispatch neighborhood-based co-responder model. As you can see in this picture here, it is a team of 3 that includes a community paramedic, a clinician, and a peer. And their focus is on crisis response in public spaces, and also primarily serving people experiencing homelessness. After the response, SCRT will follow up with the clients and connect them to services. So we interviewed 20 people who recently received their services. We wanted to know more about their experiences before, during, and SCRT, and how this experience relates to their personal goals. So we did a qualitative Sorry, this format's a little funky. So our analysis included qualitative coding of interview transcripts for common themes. And next slide. Awesome. And so what we found was that nearly all respondents preferred the SCRT model over traditional first responders. They highlighted the person-centered approach that was rooted in collaborative decision-making, and they effectively addressed their immediate needs. And I think these two quotes that I selected really exemplify this. So the one up top says all three of them, the EMT, the peer counselor, and the provider, the demeanor was, more like brainstorm. Like, how are you? What can we do? What do you need anything? And actually, they didn't say, what can we do? They said, would you like some water? That was a big deal. This one below says that they showed up just like that. They gave me the opportunity to have a choice. At the time, I didn't have a choice, but where I was at on the ground. However, the respondents did note that system-wide resources limited the team's ability to address longer-term factors that drive crises for unhoused folks. They noted the inadequate quality and capacity of current housing and healthcare systems and social services navigation. So where to go, what to do, who to talk to. So our key takeaways here is that this MCT model was preferred over law enforcement and other first responders, while satisfying their immediate survival needs, and that MCTs cannot solve long-standing issues that people experiencing homelessness in crisis face without changes to the drivers of homelessness. Thank you.
Great. Thank you, Megan. Matthew, any wrapping up comments or reflections? There's also a question in the chat if you see a little bit about models where there's a paramedic engaged, a little bit more like Cahoots or this model, and how those would coordinate if there's also a traditional mobile crisis pair going out in communities.
Yeah, that's a great question. So first of all, thank you so much, Megan. That was great. I don't have anything to add to your comments. I think you nailed it. But Dean, that is an excellent question. So San Francisco does indeed have both this street crisis response team, which is this co-responder model through the San Francisco Fire and paramedic response, as well as having a county-run mobile crisis program for adults and kids across city and county of San Francisco. The street crisis response team that Megan just shared about does not bill Medicaid, so that is outside of the Medi-Cal initiative, leveraging the the enhanced FMAP for Medicaid reimbursement that many jurisdictions and states across the country have engaged in. And so that's a program that's really primarily local funds to be able to operate, but is critical for that 911 diversion, so that rather than the law enforcement response, that they're getting these behavioral health paramedic specialty responses. I will say that there's a lot of coordination between these two programs, though. So while they're different funding streams and they're different kind of approaches and dispatch mechanisms, there's great awareness of each other across the programs and a lot of work to coordinate to make sure that every type of call is getting the right kind of response and that they're partnering together whenever necessary. So thanks for that.
And Matthew, just anytime we see any of this qualitative research around these human-to-human interactions for someone who's in pain, that's what we want, right? We don't want an authority figure. We don't want a person with a firearm. We don't want a police car. They're not universal, but they're pretty close. That's what we're looking for. And Megan, thanks for continuing that work. Matthew, any quick update on the work you're doing? I know you've moved your shop up, and congratulations on expecting another baby in the Goldman household. But how's it going in Seattle as you build out crisis facilities there?
Yeah, no, thanks for the question. So yes, as David mentioned, I'm now based in Seattle metro area working for King County, and we have an initiative here called the Crisis Care Centers Initiative, which is funding the development of 5 crisis facilities across the county, serving both adults and youth, and also expanding our residential treatment programs and investing significantly in our behavioral health workforce. So all of that work is now underway, and it is moving. We're getting dollars out the door, and really excited to be seeing some of these programs take shape. So thanks for asking.
And Matthew, are you staying engaged personally with doing some research? I know this is such a passion for you, or is the day job got you too busy?
Day job has me busy, but I can't help myself but enjoy research. So I've got a National Institute of Mental Health grant that's currently funded, that we're actually doing an analysis of some Georgia data through Georgia Crisis and Access Line, statewide data there on their crisis call centers and mobile teams. And so that's ongoing, and we are certainly interested and excited to get some research going related to what we're doing here locally in King County. So anybody on the call who's interested in research or opportunities in that regard, please do feel free to get in touch.
Thank you, Megan, and thanks for your continued leadership. Dr. Goldman, we'll see you again on the next Data Corner. For now, we're going to go in a little bit different direction. David Lloyd, Paul Galdis, some really striking new mental health parity rules update. I haven't seen an enormous amount in the press about this, but this is groundbreaking if it's enforced.
Well, that's a good caveat to put in there, David, if it's enforced. But I will tell you, it's about strengthening access, right, to mental health and substance use services. And David, if I can just tee up a little bit, I'm going to hand it off to your expertise here. But if we can go to the next slide, what you're going to see is when you think of the new rule and what's been pushed out, some of the highlights are requiring health plans to make changes when they're providing inadequate access to mental health and substance use care, meaning we're really going to look at quantifying, we're going to look at meaningful comparative analysis of access to mental health and substance use crisis care, and having to do something about it if you're falling short. Make it clear what can and cannot do. You can't have more narrow networks of care for mental health and substance use than you do for your physical health counterparts. And you also cannot have additional or more restrictive prior authorization processes when it comes to closing the gaps that exist or loopholes. Part of it is in pulling in some of the non-federal government health plans that were previously exempt from parity law. And I think the classifications that we see on the right for benefit are really important, David, as we hand it off to you on meaningful benefits provisions. And of course, you'll see I highlighted emergency care. But maybe we can talk through a little bit of this meaningful benefits provision and what it could mean to our crisis community.
Yeah, no, absolutely. And thank you, Paul and David, for the opportunity. The rule was finalized a week ago, this past Monday. So it's been about a week and a half. And one of the core new parts of what was proposed and then finalized was this meaningful benefits provision, which says that for mental health and substance use disorders, plans and insurers have to cover meaningful benefits for mental health, for mental health conditions when they're providing meaningful benefits on the physical health side. And that analysis always occurs within the classifications of benefits that are on the screen here. And since emergency, is one of the classifications of benefits, that has implications for crisis services. So, if you think about on the physical health side, what are covered services, for what are covered emergency services, you immediately think of EMS and ambulance transport, as well as emergency departments. Those are covered under basically every health plan in the country. And so essentially what these rules do, if they're implemented as we hope they will be, and enforced as we hope they will be, the obvious question becomes, well, what about mobile crisis response services for mental health? How are you providing EMS and ambulance transport for individuals experiencing a physical health emergency, but not doing so for people who are experiencing a mental health and substance use, crisis, or emergency. So, this I think can be very powerful. I should point out that under the existing rules that are now in place, there are already some states that are forcing mobile crisis response coverage and strengthening crisis receiving and stabilization, coverage through the existing parity rules, and have been doing a really good job. Washington State, their insurance commissioner comes to mind. I know Pennsylvania's also been, trying to make progress using the existing parity rules. But this new final rule, makes it even more kind of unambiguous that this should be the case, and will hopefully really force coverage of services for mobile crisis response in a way that we haven't currently seen.
So, Paul and David, this is great work. Let's get you back and get some updates on this as we move forward.
Great.
Thank you.
And that brings us to Crisis Talk. And Stephanie Hepburn, we have Wendy Morris with us today.
We do. I'd like to bring on Wendy. She is the former commissioner of Kentucky's Department for Behavioral Health, Developmental and Intellectual Disabilities, and senior behavioral health advisor at NASHBID. Wendy, when we chatted, you mentioned diagnostic overshadowing. Can you share what that means?
Absolutely. Yeah, that's when we attribute someone's behaviors to a single diagnosis. And this happens a lot for people with intellectual and developmental disabilities, especially when they're non-speaking. For an example, a person may be in the hospital and maybe they're covering their ears and banging their head, and the staff quickly jumps to, oh, this must be because of their intellectual disability, and maybe they restrain them or give them a medication. Without doing a good assessment, they may never learn the person has a toothache, they have a headache. They're overstimulated because the television is too loud. They're frustrated because they can't communicate to you in a way you understand what's going on. And so that's really scary, and it can really prevent people from getting the actual help they need. And it's also a reason why we see that people end up boarding in the emergency rooms or having these extended stays in medical hospitals, because the head banging, for instance, again, has been misinterpreted as difficult behavior. People see there's a liability. Our staff aren't able to handle this. We can't give the kinds of medications, or we can't do restraints because they believe those things are needed when in fact they're not. And what's really exciting about the Link Center, which is what your article focuses on, is we're trying to really have all in one place some things that can really help staff, families, people with lived experience try to overcome some of these. So we have a great resource library that's growing every month. We've done some great shared learning groups, which you can join the future ones or watch videos of the past. You can maybe get some technical assistance. And then one of the really exciting things that's happening is the 988 Policy Academy, where we've brought 6 states together to really continue to improve the work they've already been doing to make sure that their crisis system from start to finish is for all people, including people with intellectual and developmental disabilities.
Wendy, can you share a little bit about your steering committee as well at the Link Center?
Yes, the steering committee, I think, is one of the greatest parts, and really it feeds off a lot of what you've heard today. Our steering committee is made up exclusively of people with lived and living experience. So they all have a mental health challenge as well as an intellectual or developmental disability or a brain injury or some other cognitive disability. We just met, actually, we had our first annual meeting just last week. It was phenomenal. They provided so many really important insights that are really going to direct the future direction of the Link Center.
Thank you so much, Wendy. I'll pass it back to you, David.
Thank you, Stephanie. Wendy, this is such important work, and thrilling to see 988 integrate substance use, intellectual and developmental disabilities with mental health and suicide prevention care to be this holistic place that we can go and not have these different doors. So great work. Next week, we have Warm Lines and Peer Support Lines as allies with Howard Trachtman. And in actually coming in December, We have another debate. It says debate 2 here, but I think this is actually our 4th or 5th debate in the Crisis Jam. It was the 2nd debate in Amsterdam at our Crisis Now 3 event. And we're going to repeat that here with Errol Foster from Recovery Innovations and Dr. Renee Keep from the Netherlands, who's part of UCOMS. Maybe we'll be able to get Dr. Ursula Whiteside to facilitate that debate again about the integration of peers. We heard about the NASBID paper earlier. Allie, thank you so much for being on. The book is Running the Endless Race, and it adds to that library of lived experience, finding something wonderful in a world with no finish line. And Allie and I both share a love of Spartan races and running, so it's quite an amazing book. Thank you for joining us, and we'll see you next time on the Crisis Jam.